So if no other comments, I think we'll wrap it up. This has been a great discussion. I'm always happy to be among friends. We have reviewed and discussed a lot of information on emerging approaches to both MDS and CML. And to close, I'd like to get final thoughts from each of my panelists. So let's start with Dr. Levis.
I actually would put in one more. I'm rather pleased that we still have Taxane. I think it remains my fallback, and the sheer number of agents that are coming out, particularly in CML, is to me heartening. I think this little business with ponatinib is going to be a mere blip in the road. I'm incredibly optimistic about this disease if you think about it, and that's my opinion on CML.
Dr. Jabbour?
You know, on CML, it's a very exciting field. We have a lot of options for these patients. I think the major question I'm going to face next year is financial burden. How will I handle all these drugs in the context of pricing of the medicine? I really hope that ponatinib will be back soon. It's a great drug. Hopefully we can find the best dose and eventually prophylactic measures. In MDS, we have options. I think we're far from CML. We need to optimize the best frontline drugs. We need to incorporate the knowledge we have from mutations and all the science we have in order to offer the best treatment, to have a good monitoring, and definitely the unmet need that we discussed in the second line.
Dr. Kamroji?
I agree. This has been an interesting discussion. I think for the MDS, I see ourselves really in the discovery phase now. So it's so exciting learning about the underlying biology of the disease. We still have a lot of challenges clinically that are unmet. We don't have the same therapeutic options like CML, but hopefully we'll get there. But we are learning about the biology of disease in the past 5 years more than probably the past 100 years in MDS. So this is really very exciting. And in CML, we've made progression. There are like fine-tunements. There are financial burdens to overcome. But obviously, I think the natural history for CML have changed dramatically over the past years. So,
Dr. Mesa?
Well, I'd say that I'm incredibly excited. I mean, I think that you're seeing such a spectrum of potential options, you know, for patients both in MDS and CML, that really it's going to be an era of individualizing the care, you know, and part of that individualization I think will be based on genetics, but I think it will go well beyond that. I think the patient's factors, whether they be biological, metabolism of drugs, their heterogeneity of how they metabolize drugs, but also their input, their perspective, and even the economic pieces. So it'll be really an era of individualizing therapies. And to be able to individualize, we really need a very complex and rich set of resources to be able to individualize. Because back when we only had, you know, hammers, you know, we could only use nails.
So I really like your point about individualizing therapy based on the pharmacogenomics of our patients. We really have not paid any attention to this with the flat dosing of the ABL TKIs. We could see in our patients how some are incredibly sensitive and others aren't. And the final word goes to our molecular biologist, Dr. Behar.
You know, clinically, I'm mostly focusing on myelodysplastic syndromes, and I hope that in someday soon I'm on a panel like this where we're discussing how do you pick between the 12 different options that we have to treat patients with MDS. And I see, when I go to the ASH meeting, hope that that will be a day that comes relatively soon. I'm impressed by the number of different pathways that we hadn't even considered as potential treatments now being tested in clinical trials. And I echo with your 2 comments now about the individualization of care. Genetics is going to be just one piece of that. I think personalization is going to happen at the epigenetic level, at the proteomic level, at the metabolic level. And we're going to be looking for ways to optimally not just pick a drug for a patient, but to dose that drug for that individual patient, like you mentioned. And then using these tools then to monitor response. So being able to predict relapse early and intervene before we have bad outcomes. So I'm, again, like the rest of the panel, very hopeful that we're going to make significant progress.
Well, thank you all. And on behalf of our panel, we thank you for joining us, and we hope you found this peer exchange informative. Thank you.